Welcome to this Step 2 clinical knowledge review on trauma test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for trauma, including the primary and secondary survey, hemorrhagic shock management, abdominal trauma with the focused assessment with sonography, and head and chest trauma. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the surgery and trauma sections of first aid and your question bank before or alongside this video. So here is what we are covering today. First, we are going to learn how to recognize high-yield question stems for trauma scenarios on board exams. Second, we will apply test-taking strategies for the primary survey, hemorrhagic shock, and abdominal and thoracic trauma questions. Third, we will master the next best step question format for trauma evaluation and management. Before you continue, I highly recommend reviewing the surgery and trauma chapters in first aid and your question bank. This video is designed to teach you how to approach the questions, not to replace the foundational material. This is the most important strategy for trauma questions. The boards will give you a patient with multiple injuries and ask you for the first step. The answer almost always follows the primary survey sequence: airway with cervical spine protection, breathing, circulation, disability, and exposure. If the patient has gurgling respirations, an obstructed airway, or is unresponsive, the answer is always secure the airway first, no matter what else is going on. Only after the primary survey is complete and the patient is stabilized do you move on to the secondary survey, which includes head-to-toe examination, full imaging, and detailed history. The boards love to distract you with dramatic injuries like open fractures or bleeding, but you must stick to the sequence. Now let us talk about hemorrhagic shock classification. The boards frequently present a trauma patient and ask you to identify the class of shock and the appropriate management. Here is the key. Class 1 and Class 2 hemorrhage often present with tachycardia but maintained blood pressure. The patient may be anxious but still alert and oriented. Urine output is still above 20 milliliters per hour. This is where many students get tricked because the blood pressure looks normal, but once you see Class 3 and Class 4, the picture changes dramatically. Hypotension, tachycardia above 120, altered mental status, and decreased urine output below 15 milliliters per hour. Class 4 is immediately life-threatening with over 40% blood volume loss. The board loves asking when to switch from crystalloid resuscitation to blood products. Remember, if the patient does not improve after initial crystalloid, the answer is blood products. Let us walk through the 3 most important trauma stem patterns you will see on your exam. First, blunt abdominal trauma in an unstable patient. Look for hypertension, tachycardia, and abdominal distension or tenderness. The key is hemodynamic status. If unstable, the next step is a focused assessment with sonography, not a computed tomography scan. If the sonography is positive and the patient is still unstable, go straight to the operating room. Second, tension pneumothorax. This is a clinical diagnosis. Look for hypertension, absent breath sounds on one side, tracheal deviation, and distended neck veins. The answer is always needle decompression first. Never wait for a chest X-ray. Third, epidural hematoma. Look for the classic lucid interval pattern. Head trauma, brief loss of consciousness. The patient wakes up and seems fine, then rapidly declines. The computed tomography shows a lens-shaped or biconvex hyperdensity. This is a surgical emergency requiring evacuation. Here is your first practice question. Read this stem carefully. A 35-year-old man is brought to the emergency department after a high-speed motor vehicle collision. He is unresponsive with gurgling respirations and a heart rate of 130. His blood pressure is 80/50. There is obvious deformity of the left femur. What is the most appropriate first step in management? Take a moment to think about this. What are the key clues in this stem? The patient is unresponsive with gurgling respirations. This immediately tells you the airway is not secure. Let us walk through this answer. Step 1. Spot the pattern. You have an unresponsive trauma patient with gurgling respirations, tachycardia, and hypertension. The gurgling is the critical clue because it tells you the airway is compromised. Step 2. Apply the rule. In trauma, the primary survey always follows airway, breathing, circulation, disability, exposure. You must secure the airway before doing anything else. Step 3. Eliminate wrong answers. Option A, imaging, is part of the secondary survey, and you would never scan an unstable patient first. Option B, splinting the fracture, is important, but it addresses a musculoskeletal injury, not the airway. Option D, starting intravenous fluids, addresses circulation, but circulation comes after airway in the primary survey. The answer is C, establish definitive airway with endotracheal intubation. This is the classic primary survey question. Always go back to the sequence. Here is your next practice question. A 25-year-old woman is brought in after a motorcycle crash. Her heart rate is 140, blood pressure is 70/40, and she is confused and pale. She has received 2 liters of normal saline but remains hypotensive. What is the most appropriate next step? Think about this. She has signs of severe hemorrhagic shock, class 3 to 4, with tachycardia over 120, hypotension, and altered mental status. She has already failed crystalloid resuscitation. What does that tell you about the next step? Let us break down this answer. Read the question carefully. The patient has tachycardia over 140, severe hypertension at 70/40, confusion, and she has not responded to 2 liters of crystalloid. This is class 3 to 4 hemorrhagic shock that is not responding to initial fluid resuscitation. Now, why are blood products the answer? When a patient fails to improve with crystalloid, it means the bleeding is significant and ongoing. More crystalloid will only dilute the remaining blood components and worsen coagulopathy. The patient needs oxygen carrying capacity, which means packed red blood cells. Option A, more crystalloid, will not work because she already failed 2 liters. Option C, a computed tomography scan, requires hemodynamic stability, and this patient is not stable. Option D, a central line, is a procedure that helps with access and monitoring but does not treat the underlying problem. The answer is B, begin transfusion of packed red blood cells. Now let us talk about abdominal trauma management and the focused assessment with sonography. This bedside ultrasound is one of the most tested topics in trauma surgery. It looks for free fluid in 4 key windows: the right upper quadrant between the liver and kidney, the left upper quadrant between the spleen and kidney, the suprapubic region behind the bladder, and the subxiphoid pericardial window. The critical board rule is simple. If the patient is hemodynamically unstable and the sonography is positive for free fluid, the answer is exploratory laparotomy. Do not scan, do not observe, go to the operating room. Now, if the patient is hemodynamically stable, that changes things. A stable patient gets a computed tomography scan with intravenous contrast, which is the gold standard for grading solid organ injuries. Many low-grade liver and spleen injuries in stable patients can be managed non-operatively with serial examinations, repeat labs, and monitoring. The boards will test you on this distinction between stable and unstable management. Here is your third practice question about abdominal trauma. A 40-year-old man arrives after being struck by a car as a pedestrian. His blood pressure is 85/60 and heart rate is 125. His abdomen is distended and tender. A focused assessment with sonography in trauma shows free fluid in the right upper quadrant. What is the most appropriate next step? This question is testing one of the most fundamental rules in trauma surgery. Look at the hemodynamic status. Is this patient stable or unstable? Let us walk through this answer. Spot the classic pattern. The patient is hemodynamically unstable with a blood pressure of 85/60 and tachycardia at 125. The sonography is positive for free fluid. This is the classic unstable plus positive sonography scenario. The key distinction the boards are testing here is unstable patients with free fluid go to the operating room. Period. Option A, a computed tomography scan, is only for hemodynamically stable patients. You should never send an unstable patient to the scanner. Option C, diagnostic peritoneal lavage, has been largely replaced by bedside sonography and is rarely the correct answer on modern board exams. Option D, serial abdominal examinations, requires hemodynamic stability and is for observation of patients with equivocal findings. The answer is B, exploratory laparotomy. If you remember nothing else from this video, remember this rule. Unstable plus positive sonography equals operating room. Now let us cover some high-yield pearls for head and chest trauma. For head trauma, you need to distinguish 3 key patterns. Epidural hematoma presents with a lucid interval and shows a lens-shaped or biconvex hyperdensity on computed tomography. It comes from rupture of the middle meningeal artery and requires urgent surgical evacuation. Subdural hematoma shows a crescent-shaped bleed that conforms to the brain surface. It is more common in elderly patients and those on anticoagulants. Diffuse axonal injury presents with loss of consciousness and a relatively normal computed tomography scan, sometimes with petechial hemorrhages at the gray-white junction. For chest trauma, the three highest yield topics are tension pneumothorax, cardiac tamponade, and massive hemothorax. Tension pneumothorax is treated with immediate needle decompression. This is a clinical diagnosis, meaning you do not wait for imaging. Cardiac tamponade presents with the Beck triad, hypotension, distended neck veins, and muffled heart sounds. Massive hemothorax, defined as initial output over 1,500 milliliters from a chest tube, requires thoracotomy. That wraps up our trauma test taking strategies for Step 2. Let us review the key takeaways. Always follow the primary survey sequence on trauma questions. Airway comes first, always. For hemorrhagic shock, know when to switch from crystalloid to blood products. For abdominal trauma, remember that unstable patients with positive sonography go straight to the operating room. And for head and chest trauma, learn to distinguish the imaging patterns and know the immediate interventions. To continue studying, review the surgery and trauma chapters in first aid and your question bank. Focus on the primary and secondary survey, hemorrhagic shock classification, and the decision to operate based on hemodynamic status and imaging findings. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you prepare for your boards and your residency applications. If you found this video helpful, please like and subscribe for more board review content. Good luck on your exam.